If you have a patient in your emergency ward who is giving you basically all of the symptomatology and the clinical presentation as if suffering from a seizure or amnesia or paralysis or some sort of a serious painful disorder, all of these symptoms can have a differential diagnosis of these somatoform disorders. We can also call them as the conversion disorder or the dissociative disorder in these individuals. History taking is again very important when you, even before when you start the workup of such patients. When you get a complete detailed history of such patient, any stressful event in the life of the patient, any trauma that he or she may have gone through in the recent past, then the childhood history is again very important. All of this will give you clues towards the dissociative, towards the conversion disorders or the somatoform disorders in this patient. When we say somatoform disorders, is basically the physical symptoms that he or she is presenting or trying to present is basically having the origin of the psychiatric origin. So that is basically the person is either having an anxiety or depression, or the comorbidities can be of any personality traits as if he's suffering from any obsessive compulsive disorder or any panic attacks, and he's presenting or he's giving you all of those physical symptoms of some sort of a severe physical illness in that particular case. So the workup again is very important. When we usually perform the laboratory investigations in such people, they're going to nullify the diagnosis that was made on the clinical presentation. So that is again very important. The close checkup is again very important, just to distinguish the malingerers from the dissociative disorders, and then the dissociative disorders from the people who are suffering from the genuine illnesses. The diagnosis is again going to be, first of all, we're going to have a differential diagnosis, and out of that, we're going to work up towards the accurate or towards the final diagnosis of the patient. And then the treatment guidelines are also different for different people. Even for the different form of somatoform disorders, there are different treatment guidelines. So again, the categorization of the disorder is again very important in these people. The confusing elements, we'll be discussing them over here in this section. So the workup is again very important. The medical and the neurological history should be taken in quite a detail. Again, the childhood history is also very important. If the person is not in a state in which he or she can give you a complete history, then a collateral history is taken from a friend or even from the close relatives, and that is going to again sum up towards the diagnosis or give you clues towards the somatization or towards the conversion or the dissociative features of that illness. The neurological history is again very important. If he or she has been suffering from seizures or had any attack of paralysis in the past, that is again very important over here. The correlation with the consciousness and the unconscious emotions is very important. The primary and the secondary gains. So the history would again highlight all of these primary and secondary gains out of that particular situation that the person is in. The psychiatric profile is then visualized. The family assessment is done in quite a detail. The collateral histories are taken. In a lot of cases, we can take more than one collateral histories. We can take the history from the friends, even from the families, and even from the primary caregivers in cases of the child or in cases of the old people. History of abuse is very important. History of abuse. Abuse can be of any kind. It can be the sexual abuse. It can be physical abuse. So all of these histories have to be taken in detail. The socio-economic history has to be taken in detail. Drug history is again very important. If the person is misusing some sort of a drug, alcohol use is again going to make the person more prone to the development of all of these conversion disorders. The presence of a model is again very important. Other unexplained medical symptoms are going to be seen in such a case. Presenting the diagnosis. Now, a team approach should be there. Whenever you're going to present a diagnosis or give your final diagnosis, a team approach is going to be there. There are going to be views of different team partners. Insistence or unconscious nature of the symptoms is again very important. Highlighting the positives. So obviously, when you are having the differential diagnosis of a lot of categories, the positives are again going to be counted in each of the categories, and the one with more of the positives, that is going to be the final diagnosis in that particular patient. Normalization of the patient is very important. Stabilization of the patient is very important. Assurance of the ongoing medical treatment should be given to the patient and to the relatives as well, just to avoid any panics, any anxieties in the individual, himself or herself, and as well as the relatives or the close family friends who are present over there, reinforcing the necessity or the benefit of the psychiatric treatment individually, and as well as the family can be involved in it. So what can be the confusing elements that we have to sort up to when we are working up a case of somatization disorder? That is again very important. The history of the documented organic pathologies. So the past surgical and the past medical history, as we were already focusing on, it's again very important to take all of these history, including the drug history. If he or she has been using any drug and misusing any sort of a drug, that has to be documented in detail in the history taking examination paper. Documentation is again very important. Present organic findings, if any findings are there, they have to be documented in detail. Absence of overt psychopathologies. So sometimes the psychopathologies, for example, if the patient is suffering from the obsessive compulsive disorder, the body dysmorphic disorder, again, he's going to be underweight. He's going to have those specific features of anorexia nervosa or bulimia nervosa. Then if he or she is a type A personality, all of these features can be observed in that particular person. If he's depressed, all of these has to be documented while you're taking the history. Absence of the previous somatization disorder. Then the absence of a labile indifference. It's basically the somatization disorder, and if it's absent, that means that a person can have a genuine illness in its form. So that has to be kept in mind. The sex and age of the person is also very important, as I've already focused or already pointed out the fact that females are more predominantly affected by the somatization disorders. Then the age group that is most frequently affected is usually the teenagers, and the young adults are more frequently affected by such somatization disorders. The treatment usually consists of the spontaneous remission, the support, reassurance, and the suggestion is usually given to such patients. Invasive diagnostic approaches can be used, but they should be avoided. Therapeutic procedures only for the objective evidence of the disease if you're suspecting some sort of a genuine illness in such patients. Hypnosis is sometimes tried on, and placebo procedures, medications are sometimes given just to give a placebo effect to the person who is having that hypochondriacal delusions that he's suffering from some sort of a disease. The resolution of the underlying conflict. So again, if you have taken the history, if you have counseled the patient, you should know what is the underlying conflict in that particular person, and you can focus on that conflict just to get him out of that particular situation. The individual, family, and the psychological interventions are again very important. Physical, psychiatric rehabilitations are very important in such cases, and sometimes if it is needed, the cognitive behavioral therapies are coupled up with the appropriate medications. So over here in this section, we just summarize the workup of a patient who is suffering from the somatization disorder. So that is the end of the section. Thank you for watching sqadia.com.